¿Tienes questo? E questo?
Okay.
Ok.
Okay. Good evening, everybody, ladies and gentlemen. Thank you for being here. And thank you to Roberto Cespedes, to Leverton Curtis, and Fiorella Anguilleri for inviting me here. As you can imagine, it is difficult to speak about urine sediment after such a moving ceremony, but I will try to do the best I can do. Okay, so Fiorella, please.
No.
No. Okay. So, you know that I know the Italians and I know myself. So I will speak about the importance of the urinary sediment profile for the diagnosis of isolated microscopic hematuria, glomerular diseases, and acute kidney injury. Isolated microscopic hematuria. Definition: it is a condition which is characterized by the presence of an abnormal number of red blood cells in the urine without detectable proteinuria. What is an abnormal number of red blood cells? This is a very good question, but with not a good answer. There is no agreement on what has to be considered as an abnormal number of red blood cells for the definition of microscopic hematuria. In fact, if you go through the literature, you will find that isolated or microhematuria can range from more than 1 red blood cell to more than 5 red blood cells per eye-power field, or from at least more 1,000 red blood cells to at least 14 or more, 40,000 red blood cells per milliliter. So it's very difficult to find a definition, a common definition in the literature. Why these differences? Probably because different populations have been studied, and also probably because different methods were used for urine collection, preparation, and examination. Most of them, I think, from what I found in the literature, were not all standardized. And the importance of standardization has been discussed today. What is the importance of urine microscopy, urine sediment examination in isolated microscopic hematuria? Here there is a sentence which comes from a review of microscopic hematuria published many years ago, but still very useful. The single most important test in the evaluation of hematuria is the microscopic analysis of urine, because it often distinguishes glomerular from non-glomerular hematuria, glomerular bleeding. We have already heard about this topic several times today, starting from the very important lecture of Professor Veles this morning. So the history of isomorphic and dysmorphic red blood cells starts in 1982. Beh, intanto in italiano vi dico, è la primera vez che vengo in Cile e sono molto colpito da Santiago. Mi sembra proprio una città molto civile, molto bella, e anche essere qui in questa università dove tutto funziona bene, veramente mi... Ah no! Quasi tutto. No, ma ad esempio sono stato molto impressionato dalla partecipazione che c'è stata ieri mattina al corso pratico che abbiamo fatto sul sedimento urinario. Non so quanti di voi ci fossero, ma per me e per Fiorella è stato proprio bellissimo, una partecipazione reciproca. Sembrava di essere in un'orchestra, bellissimo.
Lo que está diciendo, ¿cierto? Muy bien. Sí, sí se entiende. Que continúe in italiano entonces.
Io posso continuare in italiano, però lì è scritto in inglese.
Gracias. No, sí. Esperemos un minuto y si no, puede ser. ¿Ahí sí? Okay.
It does work? Okay, we start. So, two types of red blood cells were described for the first time in 1982 in this paper, written by two Australian nephrologists. They described two types of red blood cells in the urine sediment: isomorphic red blood cells of non-glomerular origin and dysmorphic red blood cells, indicative of glomerular bleeding. They investigated 58 patients with glomerular diseases, and they found that 55 out of 58 had dysmorphic red blood cells, and isomorphic red blood cells were not found, and 3 patients out of 58 had mixed red blood cells, dysmorphic and isomorphic. And they investigated the urine sediment of patients with urological diseases and hematuria, and nobody of those patients had dysmorphic red blood cells. So this was a very important, a landmark paper, which makes the history of nephrology. And here you have already seen this today several times, examples of isomorphic red blood cells, all with normal hemoglobin content. Here we have a number of ghost red blood cells which have lost their hemoglobin content, and we have a subtype of isomorphic red blood cells which are crenated red blood cells, which are associated with changes of specific gravity, as it was told before this afternoon. And then we have some examples of dysmorphic red blood cells, which have a shape which is completely different from the shape of red blood cells we have saved here in our personal computer. So they are really dysmorphic, so with a shape which is not nice and not the shape, the morphology of red blood cells have usually in the blood circulation. Over the years, Fairley and Burke approach has been validated by several investigators from different countries. However, this is important, it requires operator experience. It may be associated with low inter-observer reproducibility. In fact, a dysmorphic red blood cell for one operator may be considered isomorphic by another operator. And in everyday practice, we come across almost every day some types of red blood cells which have an uncertain classification. This happened also yesterday morning. Do you remember, Fiorella, that there were some few red blood cells which we cannot say, is this isomorphic, is this dysmorphic? But one day, in 1991, this important landmark paper was published, Acanthocyturia, a characteristic marker for glomerular bleeding, by German investigators, nephrologists. They investigated the presence of 9 types of red blood cells found in the urine in a large number of diseases, some of which were glomerular diseases, while the other 8 diseases were non-glomerular urinary tract diseases. And they found that all the 9 types of cells were present in non-glomerular diseases and in glomerular diseases. But they found that, they found that only acanthocytes were present in very low number and at the lowest frequency in non-glomerular urinary tract diseases. they found they were present in glomerular diseases, absent in normal control. And in this paper, they also identified what they considered the best cutoff to supply an acceptable sensitivity and specificity to define hematuria as glomerular. And after this landmark paper, other papers have been published in 1993, 1995, 1997. All these different authors found that the cutoff to be used was 5% or more, and with a sensitivity which ranged from 73 to 100%, and always 100% specificity. And so in this, due to these papers, we can say, okay, and at this point we can say that what are acanthocytes? Yesterday we repeated several times the definition of red blood cells. And is there here someone who was present yesterday at the practical course? Please. Okay. Please tell us the definition of red blood cells in Spanish language.
La definición de acantocitos o de...
De acantocitos.
De acantocitos.
En español.
En español.
Oh, okay. Anillo is the key word. Okay. Anillo with protrusions, with blebs, one or more. Okay. And in fact, here you see the definition given by Köhler and co-workers. Acanthocytes may easily be recognized as ring forms with vesicle-shaped protrusion, phase contrast images, and scanning electron microscopy image, you see, ring and vesicles. What are the added values of acanthocytes compared to other dysmorphic red blood cells? Two added values. Can you, the translation, is it working? Okay. Due to their unique shape, acanthocytes can be identified more easily and with less subjectivity than the other dysmorphic red blood cells. Added value number two, among different authors, there is a consensus on the cutoff of 5% or more. So for us, we can consider acanthocytes a sort of lifesaver. In 2022 has been published this paper on in Kidney International on acanthocytes' 30th birthday. I do suggest to read this paper. If you need, I have the PDF in my USB key, and we can share this with you. And Fiorella will tell me how to do that, if you want to, of course. However, it must be remembered that a glomerular hematuria is possible without the famous cutoff of acanthocytes of 5% or more, since the sensitivity ranges from 52 to 100%. Where do acanthocytes and other dysmorphic red blood cells come from? So, hypothesis, morphological changes of red blood cells occur while red blood cells pass through narrow gaps of the glomerular basement membrane, which are a typical lesion of glomerular diseases. Then they fall from the capillary lumen of the glomeruli within the Bowman space. They fall into the tubular system, and here they go across very large pH and osmolality changes, which cause a sort of rigidity of the structure of red blood cells. So they cannot recover their original shape, and we find them in the urine with this dysmorphic appearance. And now, what is our approach to isolated microscopic hematuria in our specialized laboratory dedicated. I work in a laboratory which we call Clinical and Research Laboratory on Urinary Sediment at Ospedale Maggiore Policlinico in Milano. For patients with isolated microscopic hematuria of unknown origin, we perform, only upon a specific request, the red cell morphology evaluation and the search of red blood cell casts. We defined microscopic hematuria as the presence of more than one red blood cells per high power field at a magnification of 400 per. We found this, we identified, doesn't work too much. We identified this cutoff while investigating, after having investigated the urine sediment of a 70 normal subject aged from 16 to 70 years, and we found that all of them had more or less than one red blood cell per high power field. This is the reason why we use this cutoff. And we examined the urine sediment after urine collection, after the collection of the second morning of the urine produced over 2 hours. We have a standardized method for urine sample preparation. We use a centrifugation for 10 volume of urine put into a glass graduated tube with conic bottom. We centrifuge for 10 minutes at 400 G, and then we remove the supernatant urine with a water pump. We leave a fixed volume of 0.5 ml of urine, then we resuspend with a pipette, and then we put on the slide 50 microliters of urine and use always a cover slip of 24 by 32 millimeter. This is our standardized method. For each sample, we evaluate the morphology of 100 red blood cells with phase contrast microscopy. So phase contrast is the standard and method in our microscopy in our lab, and calculate the percentage of isomorphic, dysmorphic red blood cells and of acanthocytes found over the count of 100 red blood cells. In addition, we always look for red blood cell cast over 50 low power field microscopic fields. For each new patient, we always ask for 3 samples to be supplied over a period of 2 to 4 weeks. Why 3 samples? Because we want to be sure that the hematuria, which was identified, which was found the first time, is confirmed in the following samples, and to see if what we defined isomorphic or dysmorphic is still isomorphic or dysmorphic in the 2 following samples. For us, a glomerular hematuria is when we have at least 40% dysmorphic red blood cells and or at least 5% acanthocytes and or at least 1 red blood cells over 50 low power fields. There is no doubt that the 2 more important parameters for us are dysmorphic and acanthocytes, more than red blood cell cast. And this is the old instrument we used. It was a cell counter used by hematologists to identify, to count the different subtypes of leukocytes. We put a new label on the instrument, isomorphic, dysmorphic, acanthocytes. And I give you this example. We have 100 red blood cells, microscopic hematuria with 71 out of 71 dysmorphic red blood cells out of 100 examined red blood cells. 23 of these dysmorphic cells are acanthocytes. Conclusion, glomerular hematuria, very probable. The examination of red blood cell morphology is of special value for patients with isolated microscopic hematuria, for whom it is extremely important to be early and correctly addressed towards a nephrological or urological workup. You see here the very clever nephrologist and the not so clever urologist. But when I speak about microscopic hematuria to urologists, I invert and say, these are your, okay, because we have to survive. In difficult word. Okay. And now, last question. Which glomerular diseases are behind isolated glomerular microscopic hematuria? We published a paper in 2008 in Pediatric Nephrology, in which we described 16 patients with isolated glomerular microscopic hematuria submitted to renal biopsy. And we found that a renal disease was present in 14 out of 16, using our very unusual cutoff. 9 had thin basement membrane disease for children, 5 adults. 3 had Alport syndrome children. 1 adult had IgA nephropathy. 1 child had C3 glomerulonephritis. We didn't find glomerular abnormalities in 2 patients, but in 1 red blood cells were present within the tubular lumen, and the other patients, a possible explanation is that the renal biopsy didn't pick up the area in which the glomeruli were touched by the disease. We published, beside this paper, also this paper, in which we described the long-term follow-up in 42 patients with isolated glomerular hematuria followed in our outpatient clinic. Those patients had an average follow-up of 14 years after the first diagnosis of microscopic hematuria, and we found that all of them did not have a normal renal function at the end of our follow-up without proteinuria. Here we have another much larger series of patients taken from this journal, 350 patients, and again, we can see here that a large spectrum of diseases can be behind isolated glomerular hematuria. Again, there is this paper, a review, very interesting, glomerular hematuria and the utility of urine microscopy, a review. And again, I suggest you to read this paper. And if you want to, I have the PDF, which if you want to, we can share. So isolated microscopic hematuria is finished. And the question after?
Yeah.
Okay. Glomerular diseases. The urinary sediment profile in glomerular diseases. That depends on...
¿Alguna pregunta para el doctor Fogazzi? ¿Hasta esta parte? ¿O continuamos? Continuamos.
Okay. You're tired. Glomerular diseases include several clinico-pathological conditions which are associated with variable clinical manifestations and the laboratory results, including urine and urinary sediment. The variability of urinary sediment results, ranging from minor to major changes, depends on the type, extent, and severity of lesions observed at renal biopsy. So, glomerular diseases are very complicated diseases, really. And so, the urine sediment also can be complicated, because if it is true that the urine sediment is the liquid biopsy, of course, we'll find different things. We can find different things in the urine of patients with glomerular diseases. And this is the wide spectrum of urinary profiles in glomerular diseases. Isolated glomerular microscopic hematuria, which I have just described. We may have patients with microscopic glomerular hematuria plus proteinuria, typical, for example, of IgA nephropathy. We may have microscopic hematuria, isolated or recurrent, again, as it happens in IgA nephropathy, isolated acute post-infectious glomerular disease. We may have a profile of active proliferative glomerulonephritis or a profile of non-proliferative glomerulonephritis. And we may also have a profile of mixed proliferative and non-proliferative glomerulonephritis with nephrotic syndrome. And now I will speak about the profile of active profile, proliferative profile, and the profile of non-proliferative glomerular disease. First of all, what is a proliferative glomerular disease? Because it is important to know that. A proliferative glomerular disease is a condition characterized by an increased number of cells within the glomeruli. And these may be mesangial cells, extracapillary cells, intracapillary cells, or we may also include in this category necrotizing glomerulonephritis, which are these glomerular diseases characterized by glomerular fibrinoid necrosis. And here I show you some very simple examples. Here this is a normal glomerulus, Bowman capsule, Bowman space, and the glomerular tuft. Now I give you an example of a proliferative glomerular disease due to proliferation of mesangial cells. Here, this is an enlarged mesangial space with an increased number of mesangial cells. This is a typical IgA nephropathy. Then we may have an intracapillary proliferation due to intracapillary inundation of cells within the within the capillary lumens of the glomeruli. You see that the lumens of the capillary glomerular capillaries cannot be seen because they are occupied by mononuclear or polymorphonuclear cells. This is a typical acute post-infectious glomerulonephritis. Then we may have a proliferative glomerular disease due to the proliferation of extracapillary cells, which occupy this Bowman space in a segmental way or in a total way. You see the Bowman space is all occupied by the proliferative cells. And then we have the example of a necrotizing glomerulonephritis where there is a very strong inflammation which destroys part of the glomerulus. Then we have non-proliferative glomerular diseases. These are glomerular diseases with different types of glomerular lesions, but all with normal or reduced numbers of cells within the glomeruli. I give you again few examples. Normal glomerulus, and here we have a typical case of membranous nephropathy. The number of cells of the glomeruli is normal. The typical lesion is a thickening of the glomerular capillary walls due to the position of immunocomplexes and complement. Then we have focal segmental glomerulosclerosis, in which a variable proportion of the glomerulus is occupied by sclerosis, by sclerotic material. Normal part of the glomerulus and the glomerulus occupied by sclerosis. Then we may have glomerular amyloidosis. You see here, the normal tissue is very limited here, and here we have deposition of amyloidosis. And then we may have the glomerular diabetic nephropathy. This is a typical nodular lesion, again with sclerosis, replacing the normal glomerular structure. The urine sediment in glomerular diseases. In the last decades, several studies have been published in international journals, which have demonstrated in different ways, actually, the utility of urine sediment examination in patients with different types of glomerular diseases, with different numbers of patients investigated, with different particles of urine sediment considered, and so on and so forth. Among these studies, and there are 22 studies we have selected, among these studies, there is a very recent one, which has been carried out by our group, and which is published in Nephrology and Transplantation in October the last month. Here is the large group which has worked on this paper, all young nephrologists, but one, the Giovanni Fogazzi. I am everything but not young. And besides the nephrologist, there is Dario Consoni, who is a very skilled and excellent statistician. So, this paper, Patients and method. I will tell you only the main results, and I will not go through too many details from the methodological point of view. So it is a single center prospective study, which started in February 1995 up to December 2022. A study which includes patients with a clear-cut diagnosis of glomerular disease at renal biopsy in native kidneys, based on histological plus immunofluorescence investigation and electron microscopic investigation when needed. We re-examined all the urinary sediment, all the renal biopsy of those patients to be sure about diagnosis, the classification of the diseases as proliferative and non-proliferative, and also to evaluate for each renal biopsy the activity and chronicity histological scores. As to urine methodology, they were samples collected 24 hours before renal biopsy, within 24 hours before renal biopsy, and prepared according to the standardized method I have just described a few minutes ago. The urine sediments were examined in blind conditions within 3 hours from urine collection by an experienced urine microscopist, Giuseppe Garigali, in the last 15 years. Before it was me, the examiner of urine sediment. In each urine sample, we evaluated the frequency and number of red blood cells, white blood cells, renal tubular cells found in 20 microscopic fields at a magnification of 100 pair. And we also evaluated the frequency and number of 8 types of casts, each of which type was expressed as number out of the 100 casts evaluated in each sample. We included in our study only patients who had at least 100 casts over the overall examination of the sediment. And we consider these 8 types of cast: hyaline granular, waxy, fat cast, erythrocytic, leukocytic, and epithelial. And we also evaluated for all renal biopsies, as I've told, the activity chronicity index and correlated the urinary finding with these scores. The results. We collected 285 patients, 12 diseases, 6 proliferative and 6 non-proliferative. Here they are in the decreasing number, in decreasing order according to the number of patients for each disease. The largest series was IgA nephropathy, 59 in proliferative glomerular diseases, and the lowest in this category, acute post-infectious. As to non-proliferative glomerular diseases, the largest series was membranous, 59 patients again, and the lowest non-proliferative lupus nephritis, class 5. Altogether, 285 patients. Here we have another graphical and clinical characteristic of patients. The important results is serum creatinine higher in proliferative as expected than in non-proliferative glomerulonephritis, and urine proteins, gram per liter, highest in non-proliferative as expected glomerular diseases than in proliferative glomerular diseases. And now what about the frequency of cells? Blue here is proliferative, red is non-proliferative glomerular diseases. Patients with proliferative glomerular disease had a significantly higher frequency of red blood cells, white blood cells, and renal tubular cells. The largest difference between the two types of diseases for white blood cells. As to the frequency of casts, again, we had that the highest frequency was for proliferative glomerulonephritis, for red blood cells cast, white blood cell cast, and epithelial cast, while the patients with non-proliferative glomerular diseases had highest frequency of fat casts. No difference between hyaline granular and granular casts. And now we go to the numbers of cells. Erythrocytes, leukocytes, and renal tubular cells were significantly more numerous in proliferative glomerular diseases than in non-proliferative ones. These are the median number for each category. To notice that there is, for all the cells, both in proliferative and non-proliferative glomerular diseases, very large standard deviations. And the same thing we found for the number of casts: erythrocytic, leukocytic, epithelial casts were more numerous in proliferative than in non-proliferative glomerular disease, in a very, very significant way. Also, waxy casts were more numerous than in proliferative than in non-proliferative the glomerular diseases, even though the P is not as high as it is there. Fat casts were more numerous in non-proliferative glomerular diseases. No difference for the numerous of iron, granular, and granular casts. At this point, one question: how to explain the large standard deviation numbers for cells and casts found in all glomerular diseases? Answer: in every glomerular disease, the number of cells and casts was very variable according to the type and the extension of histological lesion and the histological activity and chronicity scores, the results of which, for problems of time, I didn't put in this presentation. Here you see, for instance, that the number of red blood cells is very high in necrotizing glomerulonephritis, while it is much lower in patients with proliferative lupus nephritis class 3 and class 4. And again, the highest number for the diabetic nephropathy in non-proliferative glomerular diseases, and lowest, as expected, in minimal change disease. So there is a variation of numbers which depends on the type of the disease and on the clear histological activity and chronicity scores. Summary of our results. Proliferative glomerular diseases had significantly higher frequency and numbers of red blood cells, white blood cells, renal tubular cells, and of cellular casts. Non-proliferative had higher frequencies and number of fat casts. The higher numbers of red blood cells, white blood cells, renal tubular cells, and of cellular casts correlated with higher activity scores and retinal biopsy, while the higher numbers of fat casts correlate with lower activity score. So the number of red blood cells of cells and casts depends on the type of glomerular disease and the histological activity and chronicity scores. The higher the activity score, the higher is the number of cells and casts. The best markers of urinary sediment to predict a proliferative glomerular disease were the number of red blood cells, white blood cells, renal tubular cells, and red blood cell casts. These are the AUC which we obtained. At this point, we were able to create these ROC curves with AUC results, which say that the combination of urine sediment and red blood cells, white blood cells, and red blood cell casts supply discrimination between the two types of diseases with an AUC of 0.90. This was superior to that obtained with a combination of patient gender, age, serum creatinine, and proteinuria, AUC 0.84. But if we put all these variables together, we can obtain an AUC of 0.96. At this point, based on our results, we created a spreadsheets which are published in the journal as supplementary material. This is a spreadsheet based on Excel method, and it is I think it is very useful because we have a model with 5 variables in which you have male, gender, age, serum creatinine, and red blood cells and white blood cells found in 20 hour per field. And putting together all these parameters, we have the probability. Then we have a model with 6 variables to which we have added proteinuria, a model with 7 variables in which, besides red blood cells, white blood cells, we also have renal tubular cells and red blood cell cast, and here with 8 variables in which also we have proteinuria. Conclusion, our prospective study based on standardized procedures for urine collection, preparation, and examination, which included the presence and number of 3 types of cells and of 8 types of cast, and a high number of patients with 12 different types of biopsy-proven glomerular diseases demonstrate that urinary sediment is a very useful tool to predict the presence of active proliferative glomerular diseases. Not only to predict, but also to evaluate their course over time, especially if you use our spreadsheet, which I have just shown. Okay, I have finished for glomerular diseases. Questions, or can I go on with acute kidney injury? I go on. You want to eat dinner? Okay. A simple definition for the everyday clinical practice: decline of renal function occurring over hours or days without reduced urine output in a variable clinical context. Of course, from the nephrological point of view, a scientific point of view, this is a very, basic definition. But it is very useful. This is more difficult and is not for this type of audience. So acute kidney injury is a rapid progression increase of serum creatinine, and that's it. The causes, we know that there are pre-renal causes, intravascular volume depletion of whatever cause, renal causes, all types of acute glomerular renal diseases, acute glomerular diseases, acute interstitial nephritis, acute large or small vessel disease, vasculitis, acute intertubular obstruction caused by crystal, for example, and post-renal acute urinary tract obstruction. Okay. One important clinical point: pre-renal and renal acute kidney injury can be associated or not with a renal lesion, which is acute tubular necrosis. For clinicians, it is extremely important to know whether acute tubular necrosis is present or not, because this has important clinical and therapeutical implications. What is acute tubular necrosis? This is an image which shows normal tubules, back-to-back tubules with very normal cells, mononuclear cells, identical to the cells we find often in the urine. While here we have a kidney with acute tubular necrosis, you see with destroyed tubular cells, completely different from this. And again, you see here. And then we have an area, a tubule, which has lost almost completely its epithelium, which has been damaged and destroyed, and what remains of these cells fall into the urine. Another typical lesion of acute tubular necrosis is the presence of tubular cells within the tubular lumen, because see, if there is the damage of a tubular epithelium, the cells detach and they fall into the tubular lumen, and they can be in the tubular lumen either free or within, you see, cast. Here there is a cell within cast, and we have cells within cast. At this point, it is important to know that we, clinicians, nephrology, we know that there are traditional urinary markers useful to distinguish acute kidney injury without acute tubular necrosis. Very simple parameters: osmolality, higher than 500 without acute tubular necrosis. With acute tubular necrosis, less than 500. Specific gravity, more than 120, less than 120 with tubular necrosis. Sodium excretion, less than 20 millimole per liter, no ATN, more than 40, yes ATN. Fractional excretion of sodium, less than 1%, no ATN, more than 1% or 2%, yes ATN. In addition, recently, new biomarkers have been introduced, which can be used to distinguish acute kidney injury with or without acute tubular necrosis. This is kidney injury molecule 1, KIM1, interleukin 18, and neutrophil gelatinase associated hypokalin, etc., etc. These are well-known parameters by nephrologists. But not so many nephrology know that the absence or presence of ATN can also be recognized with the urine sediment examination, as demonstrated by several studies. Which studies? Here we have a landmark studies on urine sediment in acute kidney injury. Chola, 2008, from the United States, a pilot study on 18 patients. He used a urinary sediment score based on the number of granular casts and renal tubular epithelial cast per low power field. Then there are the 3 studies of the group of Mark Peracella from Yale University. Large number of patients, prospective studies with a urinary sediment score based on the number of granular casts and free renal tubular cells found per high power field. And this study used the urinary sediment score used by Peracella in patients with acute kidney injury associated or not with an infectious disease. Allora, we don't have time to go through the details of these studies, but we can summarize the results of these studies. And these studies demonstrate that renal tubular epithelial cells casts, and coarse granular casts are reliable markers of acute kidney injury associated with acute tubular necrosis and acute kidney injury associated with they are a very sensitive, specific indicator of the acute kidney injury and severity and its outcome. In addition, in the 2 studies of those listed before, it was found that these parameters, they correlate very well with the new biomarkers of tubular damage. And this is important because the new biomarkers are not available in all institutions. For instance, in our hospital, Policlinico of Milano, we don't have these parameters. Do you have here new biomarkers for urine biomarkers for distinguish acute kidney injury without ATN? Do you have or not? And urine sediment you have? Do you have your urine sediment? You don't have? Yes, you have urine sediment. Okay. So we can do what you cannot do with the new biomarkers. And in addition to the paper I've just mentioned, there is one more recent paper, 2021, which was mentioned also this morning by our colleague Juan Carlos Velez, by Varghese, United States. 222 patients with a single urinary sediment examination and 121 patients with serial urinary sediment examination. Both groups were investigated with the Chola and Peracella scores. Results: both scores correlated with the severity and outcome of acute kidney injury. Good. But especially the serial urinary sediment examination offered the possibility to follow the course of acute kidney injury with an increased diagnostic sensitivity for the identification of cases with acute tubular necrosis. I again go back to what I have just said while I was speaking about glomerular diseases. The urine sediment is useful not only to diagnose the renal diseases, but also to follow their course over time in patients, for instance, who are under treatment, okay? Not only diagnosis, but also surveillance over time. So this is another added value of urinary sediment examination. Here I show you the ATN markers. Here we have renal tubular cells well preserved. And we have an aggregate of these cells, which means there is a fragment of tubular epithelium, not a good sign for the kidneys. But we must know they may be found also very damaged, so damaged that they, for instance, they are similar to decoy cells in this case. So it is important, but they may be well preserved or very damaged, and we must learn to identify them correctly. Then we have the epithelial cast, which can, of course, contain different amounts of renal tubular cells. Here the matrix of the cast is not evident because it is the tubular cells are packed. Here we can see the matrix, the uromodulin matrix of the cast. And then we have the coarse granular cast, which coarse the coarse granules of which derive from the degeneration of probably from tubular epithelial cells. Thus, recommendation for the everyday practice: examine the urine sediment in all patients with acute kidney injury. All. No renal tubular cells, epithelial cast, granular cast. No ATN. Yes, renal tubular cells, epithelial cast, granular cast. Yes, ATN. And the higher the number of these three elements, the more likely and severe is the ATN. And now, in addition, ATN can be present in all diseases which affect the kidney, acute diseases which affect the kidney, such as I have already said that, acute glomerular diseases, acute interstitial nephritis, large or small vessel diseases, acute tubular obstruction. This is important. In these conditions, besides the three famous elements, other particles which can be found, which can tell us which disease is behind the acute kidney injury. I give you some examples. We have renal tubular cells, epithelial cast, coarse granular cast, and high number of dysmorphic red blood cell cast, active proliferative glomerulonephritis. We have the famous three particles, plus white blood cells, plus isomorphic red blood cells, plus white blood cells cast, acute interstitial nephritis. Hypothesis: hemoglobin cast, intravascular hemolysis. Crystals free and or within cast, plus renal tubular cells, etc., crystalline nephropathy. And this is my conclusion. This is a very important added value of urine sediment compared to other markers such as urine osmolality, specific gravity, sodium excretion, and the new biomarkers. The urine sediment allows us not only to see to say if there is or not acute tubular necrosis, but also to identify which diseases are behind the acute kidney injury. I have finished. Thank you for your attention. Do you have questions? Yes, we want to know what is the menu. Oh, I know nothing about the menu. So you don't have questions? Okay. Excuse me, I have the feeling that it was too much a nephrological topic.
Quería preguntarle, por ejemplo, la enfermedad insuficiencia renal es una enfermedad degenerativa que en mi país avanza bastante. En ese caso podemos encontrar hematíes crónicos y usted como médico clínico, ¿qué podría aconsejar a las personas? ¿De qué manera podría cuidar su riñón?
Aiuto.
Ho detto che in Perù c'è insufficienza renale. In questo caso si pongono dove i rossi di
¿Qué tipo de insuficiencia renal acuta? Oh, okay. But if you have an acute kidney injury with red blood cells, with erythrocytes in the urine, you have two possibilities. The main two possibilities is an acute glomerulonephritis, and in this case, so acute tubular damage, acute kidney injury, due to a very active proliferative glomerulonephritis, which causes the presence of renal tubular cells, epithelial cast, and granular cast, and or granular cast, and the red blood cells due to the glomerular disease. In this case, you will have dysmorphic red blood cells. Another possibility, you may have acute kidney injury due to interstitial nephritis. In interstitial nephritis, isomorphic red blood cells can be found, and in our experience, in a retrospective study we have published many years ago in JASD, hematuria is present in 50% of cases. How to prevent this disease? We must know what is the cause of the disease. If you say that there are red blood cells, the two main possibilities are these, okay? If there are only red blood cells besides those particles, but if there are, for instance, red blood cells and also crystals, this is a crystalline nephropathy. Do you know something about crystalline nephropathy? Okay, another question? No. Okay.
Question. En el cóctel le pueden preguntar. Thank you. Thank you very much. Oh, very good. Yeah. Doctor, come to present.